sorry for the delay. And I'm from basically from Bangladesh. They have talked a lot about Bangladesh, but I work in South Africa, settled down in US. I'm multinational, you can say. I worked in Africa for the last 5 years, basically in pediatrics, HIV, and TB. So my study is on TB and HIV, and what we are doing in our NICU and PICU and our pediatrics outpatient, you can say every second patient is a HIV positive patient. Every third patient will be TB and HIV TB combined. So I deal all these things. Thank you. This is child mortality in the world, in Africa, and in present time. The global child mortality has dropped to 53%, irrespective of before and previous one. In 1990, it was 12.7 million in 1990, and this year, 2015, it is 5.9 million. Global mortality. Again, the sub-Saharan Africa where I work still has the highest child mortality rate in the world. And South Africa has reduced its child mortality rate from 60 deaths per 1,000 live birth in 1990 to 41 in 2015, though our MDG target is 20 only. I also contributed some of them. Our study was meconium aspiration in babies born with HIV positive mothers. Study done in Stanger Hospital, is a tertiary hospital, Durban, South Africa. Time period was 2011 to 2013. We exclusively taken 500 newborn having meconium aspiration only. We closely studied the NICU and neonatal wards. We are looking for two things there. Most of the NICU babies or mothers are HIV positive. I say it as every second mother is a positive in HIV. Our study is to find out HIV positive mothers' babies are more prone to meconium aspiration or not. That was our main study. And the second one about PCP. As in our NICU and neonatal ward patients' mothers, 80% of them are HIV positive. They are already on ARV or newly diagnosed on ARV. Some of the mothers are diagnosed in third trimester of the pregnancy, or some of the diagnosed during the labor. We have a protocol like that to study all the mothers. The total neonatal ward and NICU admission in Stanger Hospital around 2,000 in 2 years of time. Approximately, I'm talking. Of them, approximately 1/4, around 500, are diagnosed as meconium aspiration syndrome. 80% of all admission of the newborn baby's mother are HIV positive. I'll discuss it all the end, the results of our study in the end, in one slide only. Now let's see what is meconium aspiration. As all of us know about this, but just a reminder to us. When a newborn inhales a mixture of the meconium, amniotic fluid from the uterus just after birth, this is meconium aspiration. What is meconium? We know it. What is amniotic fluid? I can go on all these things. These are common things. Let's go to the study. Meconium stained baby found in 10 to 15% all of the births. This is 10% in the developing country, we can say 15 to 25% in developing country. It generally happens in after 34 to 42 weeks of gestation. 30% of all of them needs ventilation. In the developing countries like industrialized countries, meconium is, as I say, detected in 8 to 25% of the all births. After 34 weeks of gestation, of these newborn with meconium stained amniotic fluid, approximately 10% develop meconium aspiration syndrome. In developing country, it is simply a bit different than the developed country. Factors, go back. What are the factors promote the meconium aspiration? As placental insufficiency, maternal hypertension, pre-eclampsia, oligohydramnion, all these things, inadequate removal of the meconium from the airway prior to the first breath, use of positive pressure ventilation prior to cleaning the airway. In some of the hospitals, they do like that. Cause of meconium aspiration can continue. There are a lot of things. We almost all of them know it. The inhaled meconium can cause partial or complete blockage of the airway, causing difficulty of breathing, that is, and poor gas exchange in the lungs. In addition, this substance is irritating and causes inflammation in the airways and potentially causes chemical pneumonia. These are the way how it helps meconium aspiration syndrome, all our physiology. Meconium particles in the ammonite fluid can block small airways and prevent the exchange of the oxygen and carbon dioxide after birth. Some babies have immediate respiratory distress, others develop respiratory distress within a few hours. The plugged airways may cause air to be tapped and leak into the tissue in and around the lungs. Infection can also occur, causing pneumonia. These are the symptoms, common symptoms: cyanosis, tachypnea, intercostal interaction, barrel chest, presence of air trapping, auscultate rales and rhonchi. Dark. What are the sign of meconium aspiration? Generally, we get the bluish, not skin color. There is cyanosis. Ammonite fluid will be greenish. Absence of breathing apnea, and infant may show sign of post-maturity. Definitely will leap or Apgar score. Physical examination, we'll see the direct visualization of the vocal cords for the meconium staining with the laryngoscope in the delivery room is the most accurate evaluation for the possible meconium aspiration. In the same time, you can aspirate the meconium. The diagnosis may be aided by the listening to the infant chest. Blood gas analysis is the most appropriate one. We can see acidosis, acidic condition of the blood, decreased PO2 and increased PCO2. And secondly, lately, you can see chest X-ray showing patches, stretchy. This is what we'll see in the X-ray. Almost all of us saw all these things. Specific treatment, but based on the following: the amount and thickness of the meconium, the length of the time of the baby was exposed, the degree of the respiratory distress. At delivery, treatment may include suction of the upper airway. They say M and O, mouth, nose, and oropharynx, how you suck from where first. Suction of the lower airway through an endotracheal tube placed in the windpipe. This is American Academy of Pediatric guidelines. The baby is not in, if it is depressed, respiratory effort is, heart rate is less than 100, use direct laryngoscopy, intubate and suction the trachea immediately after delivery, suction for no more than 5 seconds. If no meconium is reactivated, do not repeat intubation and suction. If meconium is reactivated and bradycardia is present, re-intubate and continue suction. If the heart rate is low, administer positive pressure ventilation and consider suctioning again later. There are guidelines too. If the baby is vigorous, but that means is the heart rate more than 100, we should not electively intubate. Clear secretion and meconium from the mouth and nose with the bulb syringe or large bore suction catheter is enough. In both cases, this reminder of the initial resuscitation steps should ensure, including drying, stimulation, and repositioning, administering oxygen, and necessary. Maintain an optimal thermal environment, minimal handling of the patient. Baby's sedation is often necessary to decrease the agitation. And we can continue respiratory care. Oxygen therapy via hood or positive pressure is critical in maintaining adequate arterial oxygenation. Mechanical ventilation is required by the approximately 30% of the infants with meconium aspiration syndrome. May concentrate approach minimize the minimum airway pressure and to use this short and inspiratory time. Oxygen saturation should be maintained at 90 to 95% of these babies. Ensure adequate oxygen carrying capacity. Corticosteroids are not recommended. ECMO is used if all other therapeutic options is even exhausted, although effective in treating meconium aspiration syndrome by ECMO is associated with a high incidence and poor neurological outcome. Surfactant therapy is commonly used in displaced or inactivated surfactant is a detergent to remove the meconium. Although surfactant use does not appear to be affect mortality rate, it may reduce the severity of the disease and progression to extracorporeal membrane oxygenation. That means ECMO studies are ongoing to evaluate the potential role of pulmonary lavage with surfactant. These are nowadays, some places they studied and they continue like that. They use potential role of pulmonary lavage with surfactant. For treatment of persistent pulmonary hypertension, newborn inhaled nitric oxide is pulmonary vasodilator for the choice. In some center they use it. Most of the centers they do not use it. Prevention is the best way. The obstetrician should be trained for that. When meconium is detected, ammonia infusion with warm, sterile saline is theoretical beneficial to dilute the meconium. These are not, however, currently evidence that does not support the routine amino infusion to prevent meconium aspiration syndrome. Theoretically, they can say like that. Current recommendation no longer advise routine interpartum suction for infants born to the mothers with meconium staining amniotic fluid. When aspiration occurs, intubate immediate suction of the airway can remove much of the aspirated meconium. I don't want to continue here. Complication is respiratory distress generally subside within 2 to 4 days, although the rapid breathing may persist for days. Infants with severe aspiration that require mechanical ventilation have a more guarded outcome. Lack of oxygen in the uterus or from the complication of meconium aspiration may lead to the brain damage. The outcome depends on the degree of the brain damage. Meconium aspiration rarely leads to the permanent lung damage. Continue with the complication, aspiration pneumonia, pneumothorax, persistent fetal circulation, residual brain damage due to lack of oxygen, persistent respiratory distress. Respiratory distress lasting for several days, persistent pulmonary hypertension of the newborn as a result of the chronic uterus stress and thickening of the pulmonary vessels, surviving PPHN babies having persistent hyperventilation up to the 5 to 10 years of life. Mortality and morbidity. The mortality rate for the meconium aspiration syndrome resulting from the severe parenchymal pulmonary disease and pulmonary hypertension is high as 20%. Other complications include air block syndromes and pulmonary interstitial emphysema, which occurs in 10 to 30% of infants with the meconium aspiration syndromes. Well, the take-home message to us is take good obstetrical history before resuscitate a baby. Suction and good suction, as I said, mouth, nose, and oral repeatedly. Use of conventional ventilator. Use of surfactant sufficiently, effectively, and timely. use of high-frequency oscillation, ventilation. Those centers who do have the use of nitrous oxide and ECMO. Conclusion of our study, we do not find any correlation between meconium aspiration syndrome and the babies with HIV-infected mothers, neither in morbidity nor in mortality. We had an emphasis that we will get some interesting story that the mothers having HIV, the child will develop early meconium aspiration. So we got that study, but it is nothing to do with HIV. But we definitely find correlation between HIV and infected mother-child developed PCP in the later stage of life. That is another study, maybe another seminar I will present that. We have done that also. In a developing country like Sub-Saharan Africa, use of CPAP, ventilator, and high-frequency ventilator, ECMO, and even surfactant is not available in time of necessary in the public hospital, even in South Africa, though it is a developing, you can say, developed country in some places. The reasons morbidity and mortality are more in developing country, we can expect it. Thank you. These are the...
Any questions? I have a question, Dr. Anwar. So my main practice is respiratory care specialty. And recently, there were some studies out of Poland which showed that the use of helium-oxygen mixtures were advantageous in patients with meconium aspirations. And so what they actually looked at was, did the patient, was he on conventional ventilator? Did they transition over to high frequency with nitric, or did they go to ECMO, or did they come off the vent? Surprisingly, and this is only a case review of so many patients, but the patients actually came off the ventilator without going to all these other invasive procedures. And so the use of helium-oxygen mixtures has actually been around since the 1930s, but it hasn't been really studied in detail. And so meconium aspiration, as you showed in your slides, is an obstructive airway or airway flow obstruction. And so the helium would actually help with that, and it might improve alveolar gas ventilation in these situations. And so this is something that future studies might be needed for.
Yeah. You see, in developing country like Africa even, you don't have a surfactant when you need. Mm-hmm. You don't have a aspiration or a ventilation or positive pressure ventilation, nothing you can when you really need. That's why I say effectively, timely, and efficiently. You don't have the suction machine is not working, or maybe electricity is not, the pump is not, suction machine pump is not connected, and they are sucking it is not connected even into the end. So these are the things the developing country are dealing with. You cannot expect that you will go for this nitric oxide or manco or other things, high ventilation. So mortality rate will be high. Like the primary center, health center, they send the patient to the tertiary hospital. It is already late. The brain damage is already done. Already hemiparesis or paresis is already developed. So those are the things we are facing.
Oh, yeah. And I think one of the theories when we do rescue therapies is the reason that the nitric oxide hasn't worked for pulmonary hypertension in this situation is that the airways are blocked. Yeah. And so you can't really get any effective ventilation or nitric in. Yeah, so that's what I thought.
Yeah, thank you.
Initially, you are correct. We've been using the Helios, which is a presentation I'm going to do tomorrow, for SARS-like, airflow obstructions. And so even in that situation, you have to catch it before it gets into the ARDS stage and the organ failure. Once it gets to that point, the prognosis is poor, and basically your ship is in port and ready to sail. So in situations where we used it, these patients had a severe respiratory acidosis, like a pH of 6.99, PCO2 is in the hundreds, and you'll see within 3 hours if it's effective or not, and then you can move on from there. So, thank you. Sure.
Yeah, all of it. That's a protocol.
You didn't find any correlation in the mortality and mortality?
With meconium syndrome, no. We got the PCP, development of PCP of these babies very early. I mean, so, you can find all the PCP admitted to the hospital. They are definitely positive marks. So the correlation is there, not with the meconium aspiration.
How much time did you take in PCP?
No, the second, not immediately they do. They come with the respiratory tract infection, then the pneumonia, then they develop PCP. And you find the mother is positive, already mother is in treatment, baby is not on treatment. Some of the cases come from the clinics. But our hospital, with routine protocol, the mother should be in treatment, and immediately the baby should be treatment just after delivery.
Okay.
Okay.
Thank you.
Advice to patients supplementing positive about breastfeeding in Europe.
Yeah, on breastfeeding, there are options. If mother said, I will breastfeed, you go on breastfeeding. Exclusive breastfeeding, 6 months. Exclusive breastfeeding. Nothing up to 6 months, yeah. They will continue with it.
Even with HIV?